Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're wrapping up our section on primary headache disorders with one more can't-miss condition, idiopathic intracranial hypertension, also known as pseudotumor cerebri. This one mimics a brain tumor but isn't one, and if you miss it, your patient could lose their vision. Whether you're reviewing for the PANCE, prepping for clinicals, or just want to better recognize red flag headaches, this is essential content. Did you know that IIH is most commonly seen in obese women of childbearing age, and despite normal imaging, it can cause permanent vision loss if untreated? One classic clue? A whooshing sound in the ears, pulsatile tinnitus. It's the neurologic equivalent of pressure without a mass. Let's dive a little deeper and talk about the kinderpatho. What's idiopathic intracranial hypertension? Well, IIH is a condition of elevated intracranial pressure, or ICP, without an identifiable mass or lesion on imaging. It's most common in young, overweight women of childbearing age. The exact pathophysiology isn't fully understood, but it's thought to involve impaired CSF absorption or increased CSF production, leading to pressure on the optic nerve and potential vision loss. Despite symptoms mimicking a tumor, neuroimaging is normal, hence pseudotumor. So how do these patients typically present? Well, they have daily diffuse headaches, often worse in the morning or with standing. They have transient visual obscurations like graying or blurring of vision. They might have pulsatile tinnitus, diplopia, often from sixth nerve palsy. Papilledema on fundoscopic exam is key. If untreated, it can lead to permanent vision loss. So how do we diagnose pseudotumor cerebri? Well, to diagnose it, all of the following must be present. You must have normal neuroimaging. An MRI or MRV are preferred to exclude mass or venous thrombosis. We should have an elevated opening pressure on lumbar puncture greater than 250 millimeters of water. We also will see normal CSF composition and no other secondary cause of increased intracranial pressure. On fundoscopy, we'll see papilledema as a hallmark. Visual field testing may show enlarged blind spot or peripheral vision loss. How do we treat pseudotumor cerebri? Well, first-line treatment is going to be acetazolamide, which is a carbonic anhydrase inhibitor that reduces CSF production. Also encourage our patients to lose weight. Even the modest reduction can help. Adjunct treatments include topiramate, which may help with weight loss and CSF reduction, serial lumbar punctures for temporary relief, and consider optic nerve sheath fenestration or CSF shunting if vision is threatened or refractory. We want to avoid corticosteroids unless short-term bridge to surgery. Now let's look at the book med versus the street med. So book med is going to show us a young woman with a daily headache, papilledema, and elevated opening pressure on LP. We'll give her acetazolamide and we're done. Street med is going to show us a patient that says, my vision goes black when I bend over, and describes a whooshing sound in her ears. She looks fine, but your fundoscopic exam shows papilledema. You catch it early and protect her eyesight. All right, so some clinical pearls. Always perform fundoscopy in any headache with visual complaints. Diplopia plus papilledema, think IIH. MRI or MRV rules out masses or venous thrombosis. An urgent ophthalmology referral is critical for ongoing vision monitoring, and obesity is a major modifiable risk factor. All right, now let's do some practice questions. Question 1. A 28-year-old obese woman presents with daily headaches, transient vision loss, and a pulsatile tinnitus. Fundoscopy shows papilledema and MRI is normal. What's the next diagnostic step? Is it A, an EEG, B, a lumbar puncture, C, a CT angiogram, or D, a carotid ultrasound? I'll give you a few seconds. If you said B, lumbar puncture, you are correct. Remember, LP is needed to confirm elevated opening pressure and rule out other causes. Question 2. What's the first-line medical treatment for idiopathic intracranial hypertension? Is it A, dexamethasone, B, sumatriptan, C, acetazolamide, or D, prednisone? I'll give you a few seconds. If you said C, acetazolamide, you are correct. Remember, this reduces CSF production and is the mainstay of IIH management. All right, so some final thoughts. IIH may be pseudotumor, but its impact is very real, especially when it comes to vision loss. Recognizing it early means you can intervene before irreversible damage occurs. With this episode, we've wrapped up our primary headache disorders: tension type, migraine, cluster, and now IIH. Next up, we'll shift gears and dive into secondary headaches, starting with a look at the red flags you should never ignore. In this episode, we'll break down Snoop mnemonic and why this could save a life. If this episode helped you master a tricky red flag headache diagnosis, send it to a classmate or replay it before your next rotation. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Until the next episode.